cover today three topics: constipation, diarrhea, and irritable bowel. So we're gonna get started with constipation. So constipation is one of the most frequent GI complaints in the U.S. About 2.5 million doctor visits for constipation each year. Millions of dollars are spent on laxatives yearly. Symptoms of constipation are extremely common, and we'll go through those. The prevalence is more common in women and the elderly, between 2 to 27%. Adults overall, about 16%. Older adults over the age of 60 and older, about 33%. And then you have idiopathic, affects about 9 to 20% of adults in the U.S. So let's look at the pathophysiology of it. So there are two causes. There's a primary cause and a secondary cause of intrinsic problems, and this is usually affecting the colon and the rectum. So your normal transit, which is called functional transit, or the most common, you just have normal GI motility and you're having stools frequently, but you still may experience some difficulty evacuating. The passage of the stools may be hard, and also you may have some type of bloating and abdominal discomfort. The problem gets in is when you have that slow transit, so you may be experiencing some of the same things that you do normally, but there's an abnormality within the GI transit time. It's taking a long time for you to defecate. Other problems associated with primary cause is the pelvic floor or your anal sphincter. So you have a disturbance there. This is the most frequent encountered reason for defecation disorders, is a problem with the anus and with the pelvic floor. Sometimes doctors may recommend some type of conditioning for the pelvic floor, doing exercises and things, because the pelvic floor and the anal sphincter are actually applying pressure to the rectum to hold the stools. So your secondary causes are things like lifestyle factors, dietary changes, not taking in enough fluid, not taking in enough fiber, not getting enough physical activity. But then there can also be some metabolic reasons as well. There can be obstructions. You heard of anal fissures and things like that, cancer related. It can be metabolic or endocrine due to diabetes or hypothyroidism. Neurologic, like Parkinson's, systemic, scleroderma, psychiatric, like depression or eating disorders, and it can also be GI. We'll get a little bit at irritable bowel syndrome, diverticulitis, hemorrhoids, fissures, hernia, even heart failure, cerebrovascular events in pregnancy. And then, of course, things that don't fit into any of these categories, we call it idiopathic, when we really don't know what's going on. It's common for patients to have and present with more than one type of constipation, so it may be primary and secondary. All of these could be going on at the same time. Some of the other reported factors regarding constipation is inactivity. It could be low economic, socioeconomic class, lower income, the non-white race, symptoms of depression, physical or even sexual abuse. Socioeconomic, people may not have insurance or access to care based upon their income, the inability to seek treatment, and it just seems to be an ethnic barrier that's created that can also play a factor. So with the elderly, factors with the elderly is high number of daily medications, especially your anticholinergics, because they have more chronic comorbidities. Their mobility status now is waning the older that they get. Changes in their diet, not taking in enough fluid. The fiber intake may not be taking in enough fiber. Now their physical activity may be limited, being institutionalized, and then they may have just changes as well, anorectal type functional changes. So what are some of the drugs that are constipating? So some of your key drugs are your antacids, those that are containing aluminum and calcium. Then you have some of your anti-diarrheas, clonidine, cosevalam. Then of course your anticholinergics like your antihistamines, antispasmodics, phenothiazines, your tricyclic, antidepressants, iron, your non-DHP calcium channel blockers like verapamil, and of course we know about opioids and sucralfate. So looking at others, your 5-HT3, such as ondansetron. Then you have some of your antipsychotics like Abilify, Clozaril, minocycline, your osmia, which is for what? I know what osmia is for. Venturamine, topiramate is for weight loss. That's a weight loss product. Then you have your opioids like your Ultramin, Lucenta. And then what is Chantix? What is that? Smoking cessation. So these are drugs that are considered constipating. So how do we define constipation? Well, it's unsatisfactory defecation, and it's characterized by infrequent stools, difficult stool passage, or it can be both. So how do we define infrequent stool passage? That's less than 3 bowel movements per week. Less than 3 bowel movements per week. How do we find difficulty in passing stool? If there's straining, if the stool is hard and lumpy, if there's an incomplete evacuation or you feel like it's incomplete, if you're having to push for more than 10 minutes, or if you even require digital evacuation of the stool. Chronic constipation could persist for several weeks or longer. And then there's what we call IBS-C, which is irritable bowel syndrome with constipation, and we'll discuss that a little bit later under IBS.
Dr. Estes, what is digital passing of the stool?
That's actually when a physician will have to insert his finger into the rectum to see, feel if there is stool in the rectum, to feel the consistency of it. And they'll take and examine it to see, test it to see if there's any blood in the stools. That leads to a whole different process to help diagnose. That's what digital means.
Can I use colon cleanse to do that too?
I'm sorry?
Can I use a colon cleanse?
Do they use a colon cleanse? Well, we don't want to use a colon cleanse if we're trying to diagnose what's going on. A lot of times you don't see them really using colon cleanse unless they're doing a procedure. Even though a lot of people are talking, they're doing these colon cleanses and stuff, and those are not always healthy, because if you're doing it too often, you are depleting or causing imbalance in your electrolytes. So, you know, you really have to be careful if you're using those kind of like OTC. Okay. So bowel function in the process of elimination. So the normal bowel function, it serves 3 important functions. Basically what it's doing is the foods and things that you ingest, is taking them and then it's separating them. The useful part, the nutrients, things that the body needs, and then what's left over, the non-useful portions, is taking it and is storing it until it can be evacuated later, and we'll look into that. Abnormal bowel functions can include constipation, fecal incontinence, and IBS, which is irritable bowel syndrome. So when we look at the process of elimination, just like I mentioned, it's taking the things that we consume and it's separating them and it's storing them in the rectum until it can be evacuated, okay? So when you're looking at the foods and things that you're ingesting, the function of the colon is to absorb some of the water to make it solid. But if it's too much, then you get constipation. And if it's too little, then you get diarrhea. So it's a balance, trying to have a balance of what's being ingested. And if you're having problems, this is some of the results that we see. So it should move the waste to the rectum. That's where it's stored into defecation. And all of this is being done through a process called peristalsis. It's just that gradual movement, weight-like contractions, moving things along the colon, the intestines, to where it needs to be. Once the water reaches the rectum, it's held there until the waste reaches there. And most of that waste is liquid. It's in a liquid form, okay? And based upon how fast it's moving through will determine if it's diarrhea or if it's constipation, okay? So again, it's moving through this contractual-like wave that's called peristalsis. So once it's reached there, it's held until it's time to evacuate. So it keeps the waste in the rectum. That's the function of the anus. The anus has two muscles and is holding the waste that goes into the rectum. It's kind of like holding it there, making sure that it doesn't leave. And the other muscle is waiting until the time that's time for it to evacuate, and then it will relax and allow for evacuation. We talked about the pelvic muscles and the anal sphincter muscles. All of those are in place, applying pressure to the rectum to hold that product or that waste material until it's time to evacuate. So all of these muscles are playing a role in the defecation process. So this is called the Bristol stool chart. So it shows you type 1 separate part stools. Actually type 1 and type 2 is constipation, where you have the hard, lumpy type stools. 4 is normal. That's what you want it to be like. Smooth, kind of soft, sausage or snake-like, that would be considered normal. That would be kind of like ideal. It's not too hard, not too soft, or liquidy, so that will be considered normal. 6 to 7, this is where diarrhea is coming in. It's mushy, it's more liquid that's involved in it. So this is a chart that kind of help identify what those stools are. So how do we diagnose constipation? Well, in the absence of any other symptoms, what we're using, primarily they do like a CBC. And they don't really do any tests unless there's some other kind of clinical features that's going on, like we talked about, if there's diabetes or cancer, some of those endocrine and other functions and things like that that's going on, then they may do some metabolic tests just to try to rule out some other things that may be going on. A colonoscopy should not be performed to diagnose constipation. The only time you would actually do the colonoscopy is if there are what they call some alarming features, like if there was blood, like when they did that digital rectal exam and they examined the stool and they found blood in it, then they may order a colonoscopy so that they can look at the intestines overall to see, where the bleeding is and actually what's going on. So unless it's in a case like that, alarming features, blood in the stool, anemia, weight loss, now the doctor may just do it also if it's just time. If it's your time for you to have a colonoscopy, they may do one, but not in terms of diagnosing, constipation, unless there are alarming features. There are some other tests that they can do, the anorectal manometry and a rectal balloon exam. The anorectal manometer is kind of like a catheter that has, probes on it, and it's measuring pressure. It's trying to see how well those pelvic muscles and things are working, along with those anal muscles. The rectal balloon expulsion is basically they're inserting a balloon in your rectum, and they ask you to simulate having a bowel movement so that they can see the function of what the evacuation process would be like. So that's what's going on. A defibrillatory, you know what I'm trying to say? That's like a series of x-rays that they're taking when you're having a bowel movement. So they are actually having x-rays done as a bowel movement is occurring, just to see if there's any kind of structural, functional problems that's going on when you are having your bowel movement. We talked about additional rectal exam. They actually go into the rectum and they're looking to see if there is what they call occult blood, hidden blood that may be in the stool itself. The thing to know that I have here is that the person's symptoms and an examination are often all that's needed to confirm the diagnosis. A lot of these other tests and things that's going on typically may not be necessary. So just based upon taking that person's history and of what they're telling you their symptoms and things are, and doing that digital rectal exam is usually all that's needed to confirm constipation. There are some other, when the cause remains unclear, there's some other tests that they can do. A sigmoidoscope is when they're, sigmoidoscopy, can't say that, tongue twister. When they're looking at the large intestines, the lower part of the large intestine, then we have talked about the colonoscopy, when they're looking at the entire large intestines. They can do an x-ray of the abdomen just to see if there's any type of obstruction. They can do telemetry capsules, where they're actually swallowing a capsule and they're using x-rays to measure it. One example, and we've already talked about the anorectal manometry and the 5-4B. This Sigmark capsule is something, it's a gelatin-like capsule. It has these rings that's in it. The patient will swallow it, and it's actually looking at the time that you swallow it, the transit time, all the way through until it's eliminated. And those rings and that capsule will dissolve, and those rings can be measured on an x-ray to see exactly where they're traveling to. Usually it takes anywhere maybe from 24 hours for that entire capsule to go through, but after 12 hours they should be able to see what's left of those rings in the colon itself. So they're taking x-rays just to see what that transit time is like from the time that you ingest it until the time that it is eliminated. So what is our initial treatment approach? This is all according to AGA guidelines. After discontinuing any kind of medications, you kind of rule out, see what the offending agents may be, and you try to discontinue those medications, performing blood and other tests as guided by clinical features. So we said that the CBC was something that we would do, right? But anything else, like colonoscopy and other metabolic tests, when are we gonna do a colonoscopy? When there are alarming features like what? Anemia. Weight loss. Okay. And And so the only time that we would do any of the other metabolic tests would be what?
Having a pre-existing condition,
Okay. Pre-existing conditions, some of the other comorbid conditions and stuff that a person may have. Very good. So we can do a therapeutic trial of maybe implementing, giving them, fiber supplements or some type of stimulant laxative is recommended before doing any type of anorectal test. Normal transit time, slow transit time can be managed by long-term use of laxatives, but even with that, we wanna make sure that they're not being abused for other reasons. What other reasons do we have?
eating disorder.
Okay, some type of eating disorders. Anorectal tests should be performed in patients who do not respond to any of the other measures. Pelvic floor retraining by biofeedback therapy rather than using laxatives. This is where I was talking about. Sometimes there are some exercises and some things that can be done to help strengthen the pelvic floor. Because as you age, you know, those muscles and things become a little bit more relaxed and not as tight and firm as they should be. So this is an approach that can also be used. What approaches should be considered for constipation unresponsive to initial approaches? So according to the AGA, if they do not respond to laxative or first line pharmacologic therapy, then we look at some type of empirical therapy being done. If they're refractory to simple laxative, newer agents should be considered in patients that has the normal or even the, what does NTC and STC stand for? What is it? Normal transit and slow transit. And even if we are implementing things like biofeedback, if we're still having problems, we can look at implementing some of these other tests and things that we have talked about if people are unresponsive. So let's look at our PPCP, where we're evaluating clinical features. So we take a history, right? Remember we said that sometimes only based upon just the symptoms and that initial exam that the doctor does is all that is really required to diagnose constipation. So here you, as a healthcare provider, you do your PPCP. What features does the patient rate as most distress? Is it the infrequency, straining, hard stools, unsatisfactory defecation, or is it all of it? Or what type of symptoms are they having with it? Is there bloating, or are they having some pain, or they're just feeling overall unwell with it? So, in these characteristics that I have here, the bloating, pain, malaise, a lot of this is also characteristics of IBS. Asking the patient, what have you already done to try to treat the problem? What laxatives are you using? How often? If they tell you that they, we're using some laxatives, you wanna find out how often they would use them, have they tried suppositories or enemas? And even, as you suggested, maybe those colon cleansing, you wanna try to find that out. Show them the Bristol stool chart and ask them to identify about what their stools are looking like. Get a record of their prescriptions, including their OTCs. We talked about the drugs and things that were constipating, just to see if you can identify if some of those medications are involved. So you can also look at, most of this we just talked about, but getting a medical history, because we said that things like mental health if they're on those types of drugs, antipsychotics, if they're taking opioids or different types of things for other conditions, we want to, make sure that we find those out. Of course, any lab tests, those things that we said for, metabolic tests for other metabolic reasons and things, we wanna look and collect that information. So now that we've gathered all of that, we wanna try to assess if there's an underlying cause, are there any alarming features, what is the severity of it? And for treatment, we want to, of course, know what the preference is for the patient. Something that's gonna help them to be compliant, that's gonna be, cost effective for them as well. So now we wanna implement the plan, treat the specific cause of the constipation. So of course, going back to some of those metabolic disorders, those other disorders, dietary modifications, maybe we need to increase their fiber, laxatives or some type of other cathartic. Is that desired or is it contraindicated? And then we want to monitor those symptoms. Of course, education is always key and critical regarding their lifestyle and dietary habits. We implement the plan again by educating. We follow up with and monitor their safety and efficacy. If it's working, we proceed. If it's not, and we need to kind of reassess, reevaluate, and reevaluate our plan. So treatment in more detail. So non-drug treatment, this is preferred. Non-drug treatment. So what are we gonna do for non-drug treatment? Okay, increase their fluid intake. Okay, we're gonna either limit or rule out caffeine or alcohol. Try to increase their physical activity. All of this is just trying to help stimulate, replace refined foods with whole grains, eat a more bran, more fruits, vegetables, high fiber types foods. Avoid delays in going to the bathroom. When you need to go, you should never restrict that urge, because then you kind of recondition your body to not do what it's supposed to do when it's supposed to do it. So you should never, if you have to, go to the restroom, have a bowel movement, never restrict it. You need to go when your body is saying it's time to evacuate, okay? That can mess up your rhythm, and start creating problems over time if you continue to do that. Again, discontinue any type of constipating drugs if at all possible. So some of your OTC products for adults would be fiber, such as your Metamucil, most adults, and even in pregnancy, Senna or Biscadil. This is a stimulant if you're on opioids. Docusate if you're having a hard time, your stools are hard and you're having to push. You want a stool softener on board to soften that up so you have easier evacuation. Things such as Biscadil or glycerin, these are more gentle, and these do come in suppositories. If need to go soon, and if you need something gentle, then this is what's recommended, your Biscadil or your glycerin suppositories. And in children, this is something that you typically would see would be glycerin suppositories for a child that needs to go quickly. If no improvement in 7 days, then you want to refer the patient to their healthcare provider. When the stool is impacted, you can use an enema. Enemas are commonly used. There are tap water enemas, there are pre-packaged enemas that's over the counter. If the enemas fail to work, a healthcare practitioner may need to move to that digital rectal exam. Drinking a solution of salts, your PEG type products to clean the digestive tract, but this is under a doctor's supervision. This isn't something that you're just doing, on your own. After impaction, you add a dietary fiber. So after you get everything moving along, if there's some impact, then once that's eliminated, then you wanna make sure that you're adding on a daily basis dietary fiber. Use laxatives, maybe use 2 to 3 days if the bowel movement does not occur naturally. So we need to really be careful that we're following the directions and not over abusing even your OTC type products. If the stool is not impacted, then you still wanna, the first step of course is to increase intake of fluids and fiber. The laxatives and stool softeners that we talked about, whether they're bulk agents, your osmotics, or stimulants, then there's your regular prescription pharmacotherapy that can be used. And then we talked about the biofeedback or the muscle retraining of the pelvic muscles. Most laxatives are safe for long-term use if they are used appropriately. So I kind of created this table just to kind of give you an example of some of your laxative drugs, if they're bug forming, an example of what they are, psyllium, if they're cellulose, if there's stool softeners like your DocuSafe, glycerin or mineral oil, your osmotics like your PEG, stimulants like Senna, your chloride calcium activators. This is lubiprostone or linaclotide, and your opioid receptor antagonist, alvamopan. So this is a chart just to kind of help break down and give you some examples of the drugs that will fall into those categories. So according to the AGA guidelines, gradually increase fiber intake. And you can get this through your food, and you may have to use some supplements. Then you can begin to add on. So that's what you're gonna do first. Increase your fiber intake, and you can do this with food. You don't need to do anything else. You can kind of jumpstart this with your food. Then you begin to add on your other agents that we just talked about, your osmotics, your PEG, stool softeners, and things as you need them. Your suppositories administered 30 minutes after a meal when GI peristalsis has increased. And that's typically how the body should be functioning, is that after you eat a meal, you should be able to eliminate the waste from that meal. And they're saying you can administer a suppository 30 minutes after a meal, and this is when that GI, that peristalsis that we were talking about, this is when it's happening. That contract way to try to move that thing along, and that's why as it's moving along, when it gets to the rectum and is ready now to evacuate, you don't want to stop it or hinder it. That's why you don't want to delay and go into the restroom. So your first line treatment in most cases is going to be fiber. That's why we started with gradually increasing your fiber intake through food or supplements. This is the treatment of choice in pregnancy. What's the treatment of choice in pregnancy for constipation? It's fiber. Mostly improves cholesterol. It also will help with blood glucose levels, and but it does require adequate fluids. These are your bulk forming agents. I'm not going to go through these, but you need to read this chart just to see what our bulk forming agents are. I won't ask you about dosing, but I will ask you grand generic, what class that they fall under, and anything that's what unique to them. This is to take 2 hours before and after other drugs. Caution with other drugs that stick to fiber. Okay. These are your osmotics, like your PEG, your glycerin, lactulose. and look to see how they work. I will ask you that as well. I'll do your osmosis work. They contain large ions or molecules that are poorly absorbed. They draw fluid into the bowel, which distends the colon and increase that peristalsis that we talked about. This is just a continuation. Magnesium containing products is a caution in renal impairment. Do not use with severe renal impairment. So anything, like I was saying, that's unique to the product, then I can ask you about that. These are your stimulants, like your Senna. Stimulant laxatives, patients using chronic opioids, what would you prescribe? Certain opioids are more constipating than others, such as morphine is more than fentanyl. For your oral stimulant, Senna is usually your first line agent. And your stool softeners, such as Docusate, stool softener plus a stimulant laxative is what you use when your stool is hard. It's not hard, but the patient can't push it out. There's a term they call it mush with no push. So it's there, but the patient can't push it out. So stimulant alone is the usual treatment. They just need something to help push it out. It's there, but they just can't get it out. Mush with no push. OTC treatment is appropriate for short term, less than 7 days. No improvement, again, see a healthcare provider. These are called emollients, also called soft stool softeners, such as Docusate, Docusodium, your combination Senna products, or Senna. These are preferred when straining should be avoided. During postpartum, if you have an anal fissure, if you suffer with hemorrhoids, then you would use an emollient or a stool softener. This is preferred when the person shouldn't strain. You know, this is post-MI. So a person that has suffered from MI, you don't want them pushing or straining because it could affect their condition. Use when stool is hard or dry. Do not take Docusate and mineral oil together because it increases the absorption of the mineral oil. So, I'm gonna asterisk by that. Your lubricants such as mineral oil, do not take, and I just told you about that, not to take mineral oil and Docusate because it can increase absorption of mineral oil. This is your CCAs, your chloride channel activators. Now these I may ask you about dosing. And of course how they're used. So lubiprostone is used in CIC, chronic idiopathic constipation. It's also used in opioid-induced constipation with chronic non-cancer pain. And how much are you taking? It's available as a prescription in capsule form and is used in IBS-C in adult women. Look at the dose, 8 micrograms twice a day. Note the side effect, nausea, diarrhea, abdominal pain. If it's severe liver impairment, you want to decrease the dose in these indications. Your guanylate cyclase C agonist, the class, the mechanism of how it works, the products, Linzess, Trulance. Take 30 minutes before breakfast or on an empty stomach with Linzess. Administer with or without food for Trulance. Note your box warning, do not use in pediatric patients, high risk of dehydration that can cause death. So we're using this for constipation, and you see this, the side effect is diarrhea. Know how you would take or counsel your patient on Linzess, swallow the Linzess capsule whole. If needed, the capsule can be opened. Usually they're taking this first thing in the morning. If needed, the capsule can be opened. The content mixed with 1 teaspoon of applesauce or 30 mils of room temperature water. Swallow it immediately. It does have a desiccant in it that helps to protect the product. So you want to counsel your patient not to take that desiccant out of the container. And Linzess, it's a capsule, so it can be opened. True Lens is a capsule, a tablet, and it can be crushed. Then you have your Camoras, which is your Intrareg, is used inpatient only. This is only used in an inpatient setting, so make sure that you know that. Hospitalized surgery patients to decrease the risk of post-op ileus. A post-op ileus, something that's delaying that transit time. It's a Reams drug, and it's available for short-term inpatient use. So don't forget that. Intrareg is a Camora. It's used inpatient only. It's a Reams drug. Some of the others in this category is Movantic, and you can see what it's indicated for. Used in patients taking opioids. We have opioid-induced constipation. Opioid-induced constipation. Note the box warning, the potential risk of MI with long-term use, and its contraindications. Patients who have taken therapeutic doses of opioids for more than 7 consecutive days immediately prior to use. Side effect is dyspepsia. It's just a continuation of the other product, another product with Lister. So just add that to the list of Camoras. As you see, there's a lot of different ones in here, and they have things that are specific to these agents. Risk of GI perforation, contraindicated in your 3A4 inhibitors. So this is something to note here. Do not use with strong 3A4 inhibitors such as grapefruit juice. Avoid use or reduce the dose to 12.5 milligrams with the moderate 3A4, so put an asterisk by that. So these are the ages just kind of broken down, giving you some things that are unique to them. So make sure you're going through and you're looking at those warnings. This is your selective serotonin, your 5-HT4 receptors. This is motility and Zelnorm. So just know mechanism and what these drugs are and what their indications are for. So as you see with Zelnorm, it can be used for IBS-C. Discontinue with no improvement after 4 to 6 weeks. Note that it can cause suicidal ideation with this class. This schematic just tells you if there's a diagnosis of constipation. Like we said with our PPCP, you're just gonna take a history, find out what current medications they're on, and treat the underlying cause of the constipation. Part of that may be related to dietary modifications, like we're saying, was to add fiber, do it, that can be with food or with supplements. And we can look at if it's opioid-induced constipation, what do we do? We use osmotic or stimulants. We can also use leucoposton or your opioid receptor antagonist. Dietary, we can use, if it's acute, less than 3 to 6 months, the osmotic stimulants. If it's more than 6 months, which is chronic, then we could use, Benzest or some of your other products here. So clinical pearls constipation is defined as difficult or infrequent passage of stool. At times it's associated with straining or feelings of incomplete evacuation. The underlying cause of constipation should be identified so that it can be corrected, as we discussed. The foundational treatment for constipation, we said, was fiber or bulk-forming laxatives that provide 20 to 25 milligrams or grams per day of raw fiber. The major goal of treatment is 1, relieve symptoms, reestablish normal bowel habits, and improve quality of life. Make sure that you know that. What is the goal of treatment for constipation? Relieve the symptoms, reestablish normal bowel habits, improve quality of life by minimizing adverse effects of the treatment. And these are the guidelines. So do we have any questions with constipation?
How does thyroid function impact constipation?
Say it again.
How does thyroid function impact constipation?
Remember we said that those waste products, most of that is liquid. So you need something to help bulk that liquid up. You need to make it stick. You need to add something to that liquid. Fiber, is binding. So it's gonna bind to that liquid to help it more of a solid form instead of, so it can pass easily than being like diarrhea. Remember on that Bristol stools chart, we showed you what the normal bowel should look like, but that's what your fiber's gonna do. Remember, said if it's too much water, what's gonna happen?
Diarrhea.
And if it's not enough fluid, then what you gonna have?
Constipation.
Okay, so we need some fiber to add to that liquid to just get it at the right consistency of that number 4 on that Bristol stools chart so that it can be evacuated. It's not too hard, it's not too soft, it's at the right consistency. So that bulk fiber, that's what it's doing. It's bulking up that liquid enough so that it can pass. Do y'all need to take a 5-minute break?
Excuse me,
No.
my question is on thyroid.
Oh.
Thyroid dysfunction.
How does thyroid dysfunction?
She's asking how does thyroid tie into constipation, basically.
The- I don't know the exact mechanism of it, but that is a disorder that needs to be considered. It probably because of the medications that's being used in those different comorbid conditions that's being used to treat it. The condition itself, and then maybe the drugs themselves that are being used to treat those conditions can cause constipation. Okay. Any of those conditions. Anything else? So y'all don't need to take a break? I don't know if this will show. I'll probably just send this to you guys and let you look at this. This was, this person is saying that an over-the-counter product, a PEG product, made their child sick. And I was hoping that I could show this. y'all be able to hear?
Study underway now at Children's Hospital of Philadelphia is
How do I turn it
trying to find
up?
out. His approach to action is investigator reporter Wendy Saltzman with disturbing claims that children have developed
Where's my Daniel?
problems after taking.
We can hear you, Dr.
You can?
That this medication is regularly being prescribed off-label to infants and toddlers when it's not recommended for use in anyone under.
Over-the-counter medication being given to children. This study underway now at Children's Hospital of Philadelphia is trying to find out. Families approached Action News investigative reporter Wendy Saltzman with disturbing claims that children have developed neuropsychiatric problems after taking Miralax.
Jim, we've learned that this medication is regularly being prescribed off-label to infants and toddlers when it's not recommended for use in anyone under 17. And get this, the information disclosed by the FDA shows what is in this may have small amounts of the same toxic chemicals found in antifreeze.
We saw a lot of anger, a lot of rage, a lot of the aggression.
Neuropsychiatric events with paranoia, mood swings, aggression, rage.
These families all have similar stories.
I feel like my son was absolutely robbed of most of his childhood.
They say a doctor recommended a seemingly harmless over-the-counter laxative to treat their children's bellies, but the side effects some say were like a switch that was flipped, and their once happy, laughing children turned angry and dark.
He had the rage, fears, phobias, anxieties.
Jeannie Ward's daughter Nicole was placed on Miralax when she was just 3.5 years old. Within 10 days, she says Nicole turned manic, aggressive, and paranoid.
It was horrifying to see my daughter change like that and to not completely go back to normal.
Nicole is now 19 and lives in North Wales, PA.
I was a very, very happy child when I was 2. I was running around playing. In second grade, I started hating everybody. I wanted to kill everybody. I'm mad that this happened to me.
Even though the label doesn't recommend Miralax for children under 17 and limits the use to 7 days, these parents say pediatricians prescribe it like water and for extended periods of time.
She was on it for about 8 months.
Natalie Sinez from Westchester read that label. Like other parents, she trusted her doctor when he recommended Miralax for her daughter Mia.
All of a sudden, she started having this weird tics.
These families complained to the FDA and are part of a Facebook group with more than 3,000 members where other families have voiced similar concerns. Jeannie Ward also helped author a petition to the FDA asking for a warning label and investigation into Miralax. It resulted in a $325,000 study of polyethylene glycol 3350, an ingredient in Miralax, in the pediatric population.
I think they're poisoning our children.
The study was awarded to CHOP after the FDA reported 167 adverse side effects in kids. 37 of those included neurological or psychiatric responses. They also noted small amounts of ethylene glycol and diethylene glycol in tests they ran, the same ingredients found in antifreeze. The FDA tells Action News they take the health and welfare of pediatric populations very seriously and believe the label accurately conveys the risks. While the study is ongoing, they have determined there is insufficient data to demonstrate a link between PEG 3350 and serious neuropsychiatric issues in children. After repeated attempts to speak with doctors at CHOP, the hospital says they can't comment because the study is incomplete. They say they will submit their findings to the FDA.
I trust in the medical community. They actually robbed me of part of my fatherhood.
In the meantime, these parents are worried more children may be at risk. They're pleading with doctors and parents alike to stop using this powerful laxative in the sensitive, small bodies of kids.
It breaks my heart because I know how I felt and I didn't want anyone else to feel that way.
Bayer, the maker of Miralax, says studies have found it to be safe for both short and long-term use in children, but their label recommends it only for people over 17. The complete responses from Bayer, CHOP, and the FDA
Too
are
much
online
chatter.
at abc.com.
And needless to say, when CHOP does tell the FDA what its findings are, we'll have it.
Absolutely.
See, Dr. Esther, I think we're too busy drinking ginger ale.
That's what you take.
It worked.
It works. So, yeah, so we have this, hey guys, I'm still here. We're still in class. I asked you if you wanted a break. You decided you didn't want one. So we're still in instruction, okay? So we're talking about the use of Miralax in the pediatric population. So what is the take-home message here?
It's not for pediatrics, it's for people 17 years and older.
And so as pharmacists and prescribing OTC products, we need to make sure that we're following what those guidelines are. Now, this was something that was being done in clinical practice with, by physicians. But as pharmacists, we should only be going by whatever the FDA has indicated on the label for its use, okay? And we know that for, with the use of a lot of our OTC type products, most of them will tell you, well, it'll tell you to refer to your physician about with regards to dosing. But then, you know, we need to also consider the other manufacturing guidelines when it comes to recommending any type of these products. So something that we saw and recommend to adults is trying to be used in a pediatric population, and we're seeing some adverse effects that's associated with it. So just, you know, remember to follow the manufacturer's guidelines and be cautious when a doctor or someone else in healthcare is recommending something outside of what those recommended guidelines are. Somebody had a question?
No, it's on, the thing is that if your doctor told you you're buying it over the counter, right, then you're taking the doctor at their word, so you're not likely to ask the pharmacist, and when you're buying it, the pharmacist is not gonna ask you what it's for. So
But
sometimes
since
those
you
are
have
things
been
like-
informed as a
No, yeah, I
pharmacist.
understand. I'm just saying, you know,
Yeah.
that was what happened probably.
So we have a grave responsibility.
And they're not paying us.
Yeah, we're busy. That's true. Okay, guys, we're gonna go into diarrhea. So this is acute diarrhea. Infection is the leading cause of outpatient visit hospitalizations and the loss of quality of life in the domestic setting and even traveling. You heard of traveler's diarrhea. The CDC has estimated 47.8 million cases occur in the US, costing anywhere from $150 million in the healthcare economy. For many people, diarrhea represents an occasional inconvenience or an annoyance, yet at least 2 million people in the world, mostly children, die from the consequence of diarrhea each year. Becoming dehydrated because of dehydration and those electrolyte imbalances. What causes acute diarrhea? So most causes of acute diarrhea is infections with some type of bacterial or some type of viral organism. And usually it lasts or up to 24 hours. E. coli is the most common bacterial cause. Most cases are viral. They have a quick onset. They resolve within a few days without any kind of treatment. Tends to clear up within 24 hours. These cases are commonly associated with stomach flu, you said stomach bug, food poisoning, some type of gastroenteritis may be how the doctor would diagnose it. As I mentioned too, during foreign countries, during travel, you know, you have the traveler's diarrhea. It's acute because within, it usually clears up within a few days or with 24 hours or a few days, okay? Other causes of acute diarrhea could be IBS, some type of immune deficiency, if you're lactose intolerant, overuse and abuse of laxatives, certain types of antibiotics used following abdominal surgery, side effects of certain drugs. Also be aware that excess alcohol, large amounts of fruit, hot spicy foods can cause symptoms that's similar to infected diarrhea. Okay. So what is diarrhea? It's an increase in the volume of stool or frequency of defecation. One of the most common signs, clinical signs of gastrointestinal disease is diarrhea. It can also reflect primary disorders outside the digestive system, disorder affecting the small or large bowel. It's an increase in the number of bowel movements or stools that are mostly watery and loose than normal. When we were looking at our Bristol stool chart, we said that 6 and 7 on that chart, where it didn't have any kind of form or was not greatly formed, was the makings of diarrhea. So when the intestine pushes stool through the bowel, before the water in the stool can be reabsorbed. Remember, we said that if it's the liquid that goes into the colon that is already liquidy. So based upon its transit time, will determine if it's able to be, if it's gonna come out as diarrhea, or if it's gonna be in a more form as constipation. So that balance has to be right. So you can have cramps, nausea, vomiting can be present. In acute diarrhea, the passage of a greater number of stools of decreased form that we have just mentioned, that lasts for 14 days or less. So we know if it's going on for any length of time, we need to seek medical attention. Some definitions require an individual to present with an abrupt onset of 3 or more loose or liquid stools above a baseline of 24 hours. If it's persistent, it's lasting 14 days to 4 weeks. If it's chronic, it can be more than 4 weeks. With IBS-D, irritable bowel syndrome with diarrhea, recurrent idiopathic diarrhea associated with chronic or recurring abdominal discomfort that's relieved by defecation. We're going to talk about that a little bit in more detail. So look at how long the acute diarrhea. Normal lasting less than 14 days, less than or equal to 14 days. Persistent, lasting between 14 days to 4 weeks. Chronic is lasting more than or equal to 4 weeks. So what are our treatments? Drugs that can cause diarrhea. So your acetylcholinesterase inhibitors like donepezil, your antacids containing magnesium, some of your antibiotics, especially your broad spectrum, some of your anti-diabetic medications such as metformin, your anti-neoplastics, these are your oncology type meds, colchicine, drugs used for constipation, such as your laxatives, not taken correctly, that some of your prokinetics, your protease inhibitors. So these are some of the drugs that can cause diarrhea. So some non-drug treatment of acute diarrhea. Your dietary management is a priority, just like in constipation, also in diarrhea. So your dietary habits is your first priority. Looking to see what may be the cause, like if you're lactose intolerant and you want to switch your brand of maybe milk or dairy type products that you are consuming. So dietary management is one of the first things that can be done. It can be more severe, especially in children and the elderly, especially if they have comorbid conditions. But remember what we said, they can become, your children and even your elderly can be quickly dehydrated, leading to severe loss of fluids, electrolyte imbalance and stuff, and we could have major dire consequence that's associated with it. So dietary restrictions, so identifying what it is that you're eating or you're consuming, replacing the fluids and electrolytes. Fluids that contain salts and sugars are recommended, such as your ORS, Pedialyte, your, Gatorade products and things just like that, that can kinda help with that. However, a physician should be consulted during more severe or prolonged episodes, or when that dehydration, if there's rectal bleeding, if there's a high body temperature, then if they have fever, then you need to consider or consult a physician. Other products, your over the counter, like your Pepto-Bismol, Kaopeptate, Imodium, then your Lamotil, which is a C5. These are things that can be used as well. Tell me something unique about Lamotil. It's diphenoxylate atropine. What is diphenoxylate and what is atropine? Okay, one is anticholinergic. What's anticholinergic? The atropine. What is the diphenoxylate? Why is it there? Can atropine be abused? Is it addicting? Okay, so the diphenoxylate is added to prevent the addictive properties or the abuse potential of using this medication. Okay. So IBS-D, we'll look at this a little bit more in these products too. Loperamide, rifaximin, which is an antibiotic, and we'll look at those a little bit more. So now, just like with constipation, I took those products, they're broken down into their classes, and it just kind of gives you information with regards to each of them, their dosing and so forth. Again, I won't ask you, unless they're about dosing, unless I told you something that's specific that you should know. So with your anti-diarrheas, your Pepto-Bismol, the thing that I would want you to know is the contraindication. It's because of the salicylate that you don't want to use it in children. So the contraindication and the warning with your Pepto-Bismol, something that you should know. Also the side effect that you would tell your patient in counseling, that they may see a black tongue or their stools could be black. It's something that you should know. Contraindication, warning, side effects. Can cause an increased renal bleeding, renal insufficiency, and also do not take for longer than 2 days without the approval of your healthcare provider. Can cause bleeding and bruising, and like I said, that dark tongue and stool, but that's normal. That's a normal side effect of it. So you should tell your patient, don't be alarmed. But it's something that you do in counseling, you need to make sure that you are telling them that, so they don't be afraid that something is, happening. So the pyramid is something that can be used for self-care. Do not use in children. Also here, loperamide can be abused as it causes a mild opioid-like high in large quantities. So know that this is specific to loperamide. So the FDA requires using a blister pack so that they, to help limit the amount that's being used. Do not take for longer than 2 days without approval of your healthcare provider. This is Lamotil. As we mentioned, this is a C5. Atropine is anticholinergic and is used to discourage abuse. So difenoxylate inhibits excessive GI motility. The atropine is the anticholinergic, is used to discourage abuse. So subtherapeutic amount is being used. So its side effect is because it can cause mild euphoria due to the difenoxylate. Possible anticholinergic effects as well, this product. So Bentyl, just know the class, brand, generic name. This is on the Beers criteria for your, elderly. We talked about the Pamoras. Fibersi is a C4. And it's used in patients that have a gallbladder, so it's contraindicated. This is something you should know. A patient without a gallbladder, they cannot take this. If they have pancreatic disease. If they are an alcoholic, alcoholism, a patient who drink more than 3 alcoholic drinks per day or have severe hepatic impairment cannot take Fibersi. I'm saying that right. So know that the class, Fibersi, C4, and what its contraindications are. For antibiotics, how do you say that? Rifaximin. This is IBS without constipation. So this is the one antibiotic that's been FDA approved to be used for IBSD. Okay. It's costly. It relapses often, occur after months of treatment. So it's available and it's there for use. I don't know how widely it is because of the cost. And a lot of prescribers don't prescribe it just because it doesn't really have a good, what do you say? Treatment profile because of recurrent infections and stuff. So your serotonin 5-HT3s, Lotrinex, used for IBSD, approved for women only. Lotrinex approved for women only, but has, this is, I believe, a range drug. We'll talk about this in IBS, in irritable bowel. It's restricted due to ischemic colitis. Lotrinex, women only. It's a range drug due to ischemic colitis. Then we go through the same information with regards to our PPCP. Just gonna go through this. Instead of constipation, we will ask questions related to signs and symptoms of diarrhea. So this also gives you a schematic of diarrhea during your exam. If it's acute, less than 3 days, then what will you do? If there's fever or some type of systemic symptoms, telling you what to do, check feces for, and now you're in the doctor's office because you have fevers and things that's associated. If it's chronic, more than 14 days, this will be the other chart that's there. Less than more than 14 days tells you the possible cause. Is it intestinal infection? Is it inflammatory bowel? So forth, trying to rule out what it is, the cause, to select which medications. If there's no diagnosis, discontinue the drug, add loperamide, or if it was diagnosed, then whatever the specific treatment is for that. So this just kind of give you an algorithm of how to treat. So when you're counseling for diarrhea, if it's fevers greater than 101, then they need to contact their doctor. If they're having severe abdominal pain, or if there's blood in the stool, this does not get better in 2 days. If they are pregnant, a female patient, if you're pregnant, drink fluids with electrolytes while you have diarrhea, just to help hydrate. In children, you can use, or adults to Pedialyte, Infolite, or good options. Gatorade or similar products can be an alternative. For parents of children with diarrhea, if the child is less than 6 months, they should take them to the doctor. And don't be afraid that if you're prescribing something, to talk to your pharmacist about it, or if you see a patient coming in with something, and even though, a lot of customers, they don't want any counseling, if you see it, still flag and make an opportunity, make it intentional to try to share some information to those parents. A child has diarrhea and fever, cold symptoms are present, make sure you're not giving them aspirin because of the Rye syndrome. For fever or mild pain, you can give them Tylenol, some NSAIDs, Motrin, ibuprofen. A lot of times, you want to kind of alternate sometimes with that. We were talking about Bismuth, how do not use if you are allergic to salicylates, such as aspirin, some of your NSAIDs, don't give it to children. Some products contain phenylalanine, so if you have PKU, don't do this. Again, telling them about the tongue and the dark stool, that's normal, so not to be alarmed. But if you notice that there's bloody stool, and that the stool looks like coffee grounds, if you're throwing up blood and it looks like coffee grounds and stuff, then you want to make sure that you contact the doctor. Ringing in the ear, and this is talking about Bismuth, don't take longer than 2 days unless the doctor tells you to do so. These are all clinical pearls, things that you should read through. These are good things for you to know, but they also make good counseling points when you're talking to your patients. We said that they're caused by viruses and bacteria. Usually there's just minor discomfort. It's not life-threatening and usually self-limiting. These are the 4 pathological mechanisms of diarrhea: secretory, osmotic, exudative, and altered intestinal tract. So what are the 4 pathophysiological mechanisms of diarrhea? Know that. Know what our goal of therapy is: the management of diarrhea. Focus on preventing excessive water and electrolyte losses, dietary care, relieving the symptoms, treating curable causes, treating secondary disorders. Just read through all of these. We just talked about Bismuth. If you're lactose intolerant, ruling certain things out, and these are based upon AGA guidelines. Any questions about diarrhea? All right, we have one more. Y'all need a break?
No.
Nope. Okay. So we've talked about constipation, we've talked about diarrhea. Now we're gonna talk about irritable bowel syndrome. This is a common GI disorder that affects the large intestines. Can be debilitating. It involves pain, abdominal pain, bloating. There's also changes in bowel habits, because we're talking about going from constipation and diarrhea that's associated with it. The cause is unknown and there is no cure. So we have things that can treat it, but there's no cure for it. It's believed to be a disturbance between the brain and the gut, a gut-brain interaction. They call IBS a functional GI disorder because you can have normal bowel habits, and then all of a sudden also you could be faced with either constipation or diarrhea. Studies show that about 12% of people in the US has IBS. This is something that's also more predominant with females in a 2-to-1 ratio. People younger than age 50 are more likely to develop IBS rather than you're older at age 50 or more. Diagnosis rarely require lab or testing images, and it can again last for several years or be lifelong. So I put this together for you to kind of see the different subgroups. So we talked about constipation, diarrhea, and it can be mixed. It can be alternated between diarrhea and also constipation. So IBS-C, on days when you have at least one abnormal bowel movement, this is what you will see. If it's more than 25% of your stools are hard and lumpy, or it's less than 25% of your stools are loose and watery. Remember, we said most people with IBS have normal bowel movement on some days, and they have abnormal bowel movements on other days, and this is what it would look like. So with IBS-D, if it's more than 25, your stools are loose and watery, and less than 25 of your stools are hard and mixed. And with mixed IBS-M, you see that more than 25% of your stools are hard and lumpy, and the same with your stools are loose and watery that's occurring. So a lot of times we confuse IBD, irritable bowel disease, with irritable bowel syndrome. So I'll put this here to kind of show some of the differences between IBD and IBS. So IBD, irritable bowel disease, is classified as a disease. It can cause destructive inflammation and permanent harm to your intestines. The disease can be seen during diagnostic imaging, and it can increase the risk of colon cancer. With IBS, irritable bowel syndrome, it's a group of symptoms. It does not cause inflammation. It rarely requires any type of hospitalization or surgeries. There's no sign of disease or abnormality during an exam of the colon. There's no increased risk of colon cancer that's associated with IBS. As we continue, IBD, chronic inflammatory disease, involves the GI tract. This is where you see your Crohn's disease, your ulcerative colitis. That is IBD. Crohn's disease, IC, or UC, ulcerative colitis, okay? So you're seeing inflammation, you're seeing ulceration of the lining of the intestines, you got abdominal pain, diarrhea, bleeding that's going on. IBD, the GI tract is damaged. These diseases damages the GI tract. The symptoms can be different from everyone, and depending on the type of IBD, whether it's Crohn's or UC, and where the inflammation is in the GI tract. So it affects everybody differently. Now again, IBS, they call it functional because you can have you can be having normal bowel movements, but it may, depending on how it is, it could be diarrhea, or you can be faced with a little bit of constipation. The symptoms may include constipation, diarrhea, or it could be mixed. IBS have some of the same symptoms that you may see in, IBD, and we're gonna look at that. Endoscopy and radiologic tests do not show any inflammation. There is no inflammation in IBS, thank you. So again, let's look at these. In IBD, you got the pain in the abdomen, you have bloating, gas, constipation or diarrhea, and you can have inflammation. In irritable bowel, you can also have abdominal pain, be chronic or persistent. You can have the bloating, the sensation of feeling full. You can have the distension or swelling, gas, the constipation that alternates with diarrhea. But look at what else you have. You got cramping. You can have mucus in the stool. Can be caused because you overate, or stress. Have some nausea. You should have the urge to move your bowels without being able to have a bowel movement, kind of like that push with no push. And it's often relieved by just having a bowel movement. So if you can have that bowel movement, everything is well. You're good to go. That's not what you see in IBD. So one of the primary differences is IBS does not cause inflammation. There is damage in the GI tract with IBD, with the disease. You don't see that in irritable bowel syndrome. Okay, so let's look at diagnosing. So IBS is diagnosed based on your symptoms and the elimination of any other causes, kind of like with what we did with diarrhea and constipation. So you take a medical history through a physical exam, and a physical exam is done. Then they have some checklists, some diagnostic checklists. One is called Manning and the other one is called the Roman 4 criteria. Additional diagnostics, they may do a sigmoidoscopy or a colonoscopy. They could also look at your stools, also to see if there's any type of parasites and any kind, if it's infected, and occult blood. They do a CBC, they can do a ESR, and also look at some of the serum electrolytes. These are just some additional diagnostic steps that they could do, okay? So we're gonna look at these checklists, these diagnostic criteria that they have. So Manning says that this is chronic or recurring pain for at least 6 months, and you have at least 2 of the following. You have pain that's relieved with defecation, pain that's associated with more frequent stools, or pain associated with looser stools. You can have distension, that feeling of incomplete evacuation after you even defecated, and you can have mucus in the stool. So this is Manning criteria when they're trying to diagnose. They have to have had these things going on for 6 months, abdominal pain for at least 6 months, and any 2 or more of the following. That's Manning. In your Rome 4 diagnostic, this is associated with recurring pain that's greater than once a week, 1 day per week, in the last 3 months on average. The symptoms have to have started at least 6 months before a diagnosis, and they have to have at least 2 of the following. Either increase or improvement in the pain, a change in stool frequency, a change in how the stool looks. So these are some of the things that they would ask their patient when they're trying to diagnose IBS. They can look at use Manning or the Rome 4 criteria. So there's something else that they can use. It's called the Functional Bowel Disorder Severity Index, FBDSI. So this is looking at and trying to look at the severity of the illness. So it's looking at the person that they're reporting pain and the behavior. And there are 3 variables that they consider is a current pain scale, asking them, you know, on a scale of 0 to 10, what is their pain, what is their level of pain. They're looking at how chronic that it is, how long has it lasted, how many physician visits have they had to make within the past 6 months that's related to it. And then they rate all of this as mild, moderate, and severe. So the points that they have it's on a point scale. So if it's mild, 1 to 36 points is considered mild. 37 to 110 points is considered moderate. And if it's more than 111 points, then it's considered to be severe. There's also another one that they use that's called IBS SSS, the Irritable Bowel Syndrome Severity Score System. And this is a 5-item questionnaire, and it looks at the frequency and intensity of the pain that they're having, the distension, dissatisfaction with their bowel habits, how many times a day that they're going or not going, and how it's affecting their quality of life. They have a total score from 0 to 500. That's the total score, is 500. And they measure, each measure is rated like from 0 to 100. So each one of those 5 points, they get like 100 points for each one of those 5 things, for a total of 500 points. So mild is considered to be 75 to 175. Moderate, they have 175 to 300, but I think that probably should be like 176 to 300. Severe cases, more than 300. If it's below 75, they said you can consider to be in remission, that you're not suffering from IBS. So again, the cause of IBS is not fully understood. They said that this is believed to be a disturbance between the brain and the gut, but the brain, the signals and things that the brain is giving to the gut. But you know, everything is affected by some type of sensory and motor stimuli that's going on. The colon reacts to the information by contracting or relaxing its muscles, and it's excreting fluid or mucus. So this just kind of explains to you that gut-brain mechanism that they think that it's working through.
I don't think we have this.
Yeah.
You don't have the slide? Okay. Well, this. This is what, slide 13? I have some slides here that really don't need for this, but I can show that. So treatments are prescribed to treat specific IBS symptoms. So we have this broken down: diarrhea, constipation, pain, bloating, and gas. So within each of these categories for IBS, there's medications and things that's being used to treat. Most of all of these we already discussed within constipation and diarrhea. So in diarrhea, we talked about it. We're going to go through this in depth here. Alacetron, loperamide. So just look at the different groups that's used to treat these different categories. Just note that IBS treatment, there's no one size fit all, because everybody is different. Their bowel behaviors and things, they are different. So we have to look at that and we treat them accordingly. Available treatments target the symptom to provide relief. That's what we're looking at trying to do. Education, of course. This is often the first line of treatment, is just educating them. In mild cases, IBS symptoms can be managed just with diet. Diet, trying to relieve stress, different lifestyle things that's going on that may be causing it to occur. Then we can also look at medications. What medications are they currently taking, and try to determine as well. This can be an important part of relieving those symptoms, just trying to identify what they're on and also what could possibly work for them. So they may try different types of these agents and things that we're going to talk about, just trying to find the one that actually works for them. Also, psychological, because of stress, anxiety, different kinds of things that's going on. Patients may need some type of stress management. They may need to see somebody to discuss, to kind of talk their problems and things out that they're going through. Remember, it could be through some type of abuse, whatever it is that's causing the problem that can be associated with it. Okay, so in irritable bowel, we said it could be constipation, diarrhea, it could be mixed. So in constipation, we want to increase the dietary fiber. First thing, if we can get that under control, it may relieve everything and we're good to go. If not, we can also add some laxatives, followed by laxative, and then lubiprostone. In diarrhea predominant, we can use some anti-motility agents such as loperamide. If it's mixed, we have pain and bloating that's associated with IBS, then it may respond to some of our antispasmodics, some of our low dose TCAs, or some of our SSRIs we can also use. Okay. These are some of the agents, and I would want you to know mechanism of action here, brand, generic, mechanism of action. So you have your anticholinergic drugs, dicyclomine, hyoscyamine, are used as antispasmodics to relieve the pain. However, their efficacy has not been convincingly demonstrated. Lotrinex that we just talked about not too long, we said that this was a REMS drug. It's approved for treatment of women with severe IBS-D. So when you're going through IBS, you're looking for drugs that's used to treat either constipation and diarrhea. So make sure that you understand which products those are, okay? So Lotrinex is for IBS-D. Ametisa is for IBS-C. It's a type 2 chloride channel. That's its mechanism that operates in the small intestine. It's the treatment of women. Why do you think it's women? Primarily you see women. What did we say in the opening? That this disease affects primarily who?
The ratio
Is what?
the
Okay.
ratio.
So you have Linzest. It's also approved for IBS-C. This is a guanylate cyclase C. So make sure you know its mechanism and how it operates. And note that, what is that, tenapanor, that is for treatment of IBS-C in adults. So that means what? Both men and women it can be prescribed for both men and women. So again, I tried to create this little chart here to kind of break some of those, break the pharmacotherapy up where you can kind of see it at a glance of what's being used. Because the person can have constipation and diarrhea, so what you see in IBS-M can very well be used also within C and D, okay? The AGA suggests using the drugs listed over no drugs at all. Do something. You can give them something in patients with IBS. Just refer to the guidelines, try to find out specifically what what needs to be given. Tegaserod, which is for IBS-C, was approved for women under the age of 65 years without a history of cardiovascular ischemic events, such as MI, stroke, TIA, or angina. Under IBS-D, Viberzi, is contraindicated. We talked about this before, but this is kind of in your face, without a bladder, or those who drink more than 3 alcoholic beverages a day. And then we talked about the antibiotic that's used, rifaximin, that because of its cost and also because of recurrent symptoms, that it's not, there's some, discussion, I guess, about its use, or, but just note that this is the antibiotic that's FDA approved for use in IBS. This breaks down, allosetron. Again, this is a range drug. Just go through here and see that it's only indicated for women and what the criteria is. This gives you another chart for all IBS patients, what to do if it's IBS-C. For constipation, you started on an osmotic laxative. If it's abdominal pain, what you would give, including peppermint oil. If they're having abdominal pain, you can also use peppermint oil, and so forth. And this is whether they have C or D, the antispasmodics that you would use, that also include peppermint oil. If it's, so look at what it's saying you would use for first line agents to your left, constipation, abdominal pain, the first line treatment that you would use. For second line, these are what would be moderate, and then what agents you would use for third line. So clinical pearls. IBS is one of the most common diagnosed GI disorders, characterized by chronic lower abdominal pain, disturbed defecation and bloating, non-GI manifestations. Diarrhea IBS-D should be managed by dietary modifications and drugs such as loperamide. Several drug classes are involved. Make sure you know those, including your tricyclics. The tricyclics are being used for pain should be avoided in patients with pain and constipation. SSRIs, there's also some conflict regarding their use, but they're also listed as possible use for treatment. Just kind of like using the antibiotic, there's still some debate, I guess, about the effectiveness of it being used. These are the AGA, and that's it. So questions?
How many questions do you have?
I don't know. He hasn't told me how many questions that I'm required.